Hello and welcome to the Spinal Nerve Podcast. My name is Dr. Brian Joves.
And my name is Dr. Nicolas Karvelas.
And once again, we want to thank everybody for joining us. We are very appreciative of you listening, hoping you're finding value and learning a lot from the things that we're covering. We've been going through this series this year in 2021 of Back to Basics, and we want to continue on that journey. We're going to address a topic today that's something that we see on a regular basis within our patients, but maybe isn't necessarily within a purview of the things that we're going to necessarily treat. But we're going to talk about how we see this, what we're always looking out for, and ways to make sure that we get these patients the care that they need to be able to get them feeling better. But before we do that, once again, just want to say thank you for listening and watching, or however you hear our content and our education. We really do appreciate it. If you can take the time to share with somebody, to leave us a review, to make sure that you subscribe on to your favorite podcast player or on YouTube to make sure that we continue to reach more people, we would really appreciate it. But without further ado, Dr. K, please introduce our topic for the day.
Yeah, so today we're going to be addressing an important topic, specifically degenerative cervical myelopathy. And as always, we'll go through some specific categories, including the definition of that, as well as the epidemiology, the pathophysiology, the diagnostic workup, the clinical presentation, and ultimately some considerations in terms of treatment. So starting with a definition, so degenerative cervical myelopathy is defined by neurological injury to the spinal cord due to various age-related degenerative conditions of the cervical spine, ultimately resulting in the aforementioned injury to the spinal cord, secondary to both static compression as well as dynamic injury due to instability, and resulting in clinical manifestations and resulting in symptoms, including loss of hand function, dexterity, imbalance, falls, weakness, numbness, pain, and in more advanced stages, bladder and bowel dysfunction. As a quick aside, the term degenerative cervical myelopathy was introduced in 2015 in attempts to standardize the terminology and provide a clear definition and provide an outline of conditions that fall under that term. And it was really done, from a research standpoint, so that when natural history epidemiologic studies are being done, that there's a little bit more standardization there. And I just bring it up because you may also hear the term cervical spondylotic myelopathy, but just being aware that there was this effort started in 2015 to utilize the term degenerative cervical myelopathy.
Yeah. And so when we're talking about this to patients or thinking about this in general, I think obviously there's a lot of big words. And so maybe you can try to bring it into something that, if a patient presents as this, or you're concerned about it, what is the way that you actually say this to a patient, right? Because obviously the definition you gave was a very scientific definition, which is great for us to understand, but how do you relay that to patients?
Yeah, so typically when we're discussing this with our patients, we bring up the fact that disc degeneration, arthritis, these are natural processes that occur over time, but in some cases they can be more advanced. What caused it to be more advanced, can include what they've done with their body, what's happened to their body. So obviously stress over time to the spine, as well as obviously any injuries, traumatic events can accelerate those degenerative changes. And then there can be a genetic component to this, which we'll talk a little bit about when we talk about the pathophysiology. But essentially what you've done with your body, what's happened to your body, a component of family history, ultimately leading to these degenerative changes, including the disc bulging backwards into the canal, the bone spurs encroaching upon the canal, some thickening of ligaments, and the end result being that there is now narrowing where those nerves have to travel, including in the central canal where the spinal cord sits. And if that narrowing gets too significant, it can cause injury to the cord and a compression of the cord. And so, yeah, it's generally...
Yeah. And so I know we've talked about this before when we talked about lumbar stenosis, but essentially when patients think about this, I think the easy way, like you said, to talk about it is, there's a lot of reasons for it, but what's essentially happening is that canal has gotten smaller, and we're getting to the point that it's starting to put pressure on the spinal cord and it's causing changes that are, giving all of those symptoms that you described. So why don't you take us into some of the epidemiology, like who does this happen to and kind of how common is it?
Yeah, so this is a very common condition. So actually, degenerative cervical myelopathy is the most common cause of spinal cord injury in the developed world, and specifically in North America. Some statistics for the epidemiology in North America. So the incidence and prevalence. Respectively. So for incidence, 4.1 per 100,000 per year, and a prevalence of about 60.5 per 100,000. And as I said, that's specifically for North America. One, I think, important thing to think about when we're thinking about these epidemiologic and natural history studies is that when we think about, because that's a huge factor to keep in mind, is when we identify cervical stenosis on our workup, obviously including imaging, the question that comes to our mind and potentially the patient's mind too is what is the risk of developing significant clinical problems, including obviously cervical myelopathy, once we identify that cervical stenosis. And so there have been studies done, including a study out of the Journal of Spine in 2013 that essentially found that when you follow these patients over time, if they do have significant cervical stenosis, the risk of development of degenerative cervical myelopathy is 8% at 1 year follow-up, and 23%, or essentially 1 out of every 4 patients at a 3 to 4 year average follow-up time. So I think those statistics are important because they just highlight that once we do identify cervical stenosis, it's important to follow these patients closely, obviously in terms of their symptoms, as well as their neurologic exam, and potentially updated repeat imaging if we feel like that's clinically necessary, because those are not small numbers. Like I said, at around 3.5 year follow-up, 1 out of every 4 of those patients developing degenerative cervical myelopathy.
Yeah, I mean, that I remember when you first presented this data and we were going over it. I mean, 23% at 3 to 4 years is pretty profound, right? I mean, it's that's beyond our adjacent segment disease data for people who've had lumbar spinal fusion. I mean, that's a very significant amount of patients that are going to go on to develop worsening symptoms over time. And so, yeah, I mean, I agree with you. I think that's where close follow-up, physical examinations, often, repeat imaging studies are going to be necessary to make sure that we're staying on top of these patients and they don't get too far down the road that we can't correct things if they start to falter.
Yeah, and just to emphasize that close monitoring, because when we talk about the clinical presentation, we'll highlight this as well. But oftentimes, of course, there's the exceptions where the patient's presenting more emergently and they have clear evidence of myelopathy. But a lot of times, especially we are dealing with a chronic process that's developing over time. Sometimes, this presentation can be very variable and gradual and subtle in onset. So the patient may not necessarily, even be focused on the signs and symptoms that would make you start to be concerned about myelopathy. So it's a good thing to just kind of be aware that there's a variable and sometimes subtle or insidious onset of the symptoms. Now going into the pathophysiology. The pathophysiology of degenerative cervical myelopathy is very multifactorial and going to be due to both environmental as well as genetic factors. So as we had brought up, there is a family history genetic component to this, and we've kind of alluded to some things in prior talks, and not to go into too much depth in regards to those, but just to be aware that if there is some differences in terms of the collagen, in terms of genetics, that can predispose to disc degeneration, which ultimately can increase risk of conditions, obviously including myelopathy. But the bottom line is when they've done recent systematic reviews of existing genetic studies on degenerative cervical myelopathy. They have demonstrated that a family history of degenerative cervical myelopathy is a significant risk factor. And then obviously the other thing to take into consideration is if someone has congenital spinal stenosis. So there are individuals that obviously have a more pre-existent narrowing of the spinal canal, and obviously those patients are going to be at increased risk ultimately of developing degenerative cervical myelopathy as well.
So when you say a pre-existent spinal stenosis, can you explain that maybe a little bit better for people who may not kind of understand this theory of congenital spinal stenosis? Just to kind of get an idea for, let's say we have a new medical student that's listening to us and they're not really sure what that means. So what is causing that quote unquote congenital narrowing of the canal?
Yeah, so I guess the way I would respond to that would be that, in this case, it's just the actual anatomy of the spine that patient is born with. There's just not as much diameter or space for the nerves to be traveling. So, it's not that they're born with, the disc bulging in or they're not born or have this significant increased degeneration early on. It's rather that the actual dimensions of the canal itself are smaller at birth and through life. Is that?
Yeah. No, I think that makes sense. I think that's, it's important to understand, like, right, just because we presume that the canal should be a certain diameter for most people of a respective size. Some people are born with a 5-lane highway, and some people are born with a 3-lane highway, right? And so obviously there are likely genetic factors involved with that, but this is an unmodifiable thing. And so obviously that's, I think, where the congenital portion of it comes in. But so people understand, you can have patients that, have a central canal where the spinal cord runs through and all of the CSF that's, pretty darn small to start, to a diameter of, even 9 or 10 millimeter, where, that would be something that when you thought about it for some patients, it could be pretty small. That would be a very significant degenerative stenosis, but that where people who are born and live that way, that's just where they start.
Mm-hmm. Right. So we talked about the genetic and family history component of it, but obviously the other huge part is the natural degenerative cascade of the spine, or obviously, as we said, increased stress, wear and tear in the body, or injuries. And so, I know that this is somewhat review, but, I think it's just good to kind of think through it again in terms of what those changes are that are occurring in the spine. So as we've talked about in the past, some of that cascade of events that do occur with the degenerative changes in the spine include the vertebral end plate damage, compromising the delivery of nutrients to the disc, and ultimately developing the disc degeneration and disc bulging. And then the development of osteophytes at the level of the end plates themselves, and then increase because of those changes, obviously, including at the level of the vertebral end plates and discs, we're getting increased stress on the posterior elements, including the facet joints, and consequent, facet arthropathy, hypertrophy of those facet joints. And obviously, all of those changes, including the disc bulging in the canal, the increase the size of the facet joints, and the osteophytes coming into the canal, those are all going to encroach upon the canal, including anteriorly on the cord. And then with this compromise to the disc height, as well as to the vertebral body height, and also an increase in the length of the vertebral body, including due to the development of these bone spurs and osteophytes at the level of the end plates, we ultimately can get some buckling of the ligamentum flavum posteriorly. And with that buckling, oftentimes comes thickening. So you can start to picture in your head how we're getting this encroachment on the cord, from multiple directions, ultimately potentially leading to compression and injury to the cord. The other thing to keep in mind as well is that, with these changes, including the disc degeneration and loss of disc height and the facet arthropathy, we can start to get some instability at those levels as well. So some listhesis, as well as potentially some dynamic instability. And that ultimately, when we thought about when we were describing the definition, and we talked about both static as well as dynamic injury to the cord, that's where some of that can come into play in terms of the listhesis and dynamic instability. So ultimately, those degenerative changes progress to static mechanical compression of the spinal cord and dynamic injury and studying of the instability, as well as possible stretch injury, especially you can imagine when you are flexing forward because of that disc bulge and because of the development of the osteophytes at the vertebral end plate. You can imagine how the cord would stretch in those situations, and with extension having some compression due to the infolding and thickening of the ligamentum flavum. And you can also get some tethering because of the narrowing and degenerative changes as well. You can get some tethering of the cord as well. So bottom line, with the compression, with the static compression, the dynamic injury of the cord, some stretch and tethering, ultimately we start to get injury to the cord. And these injuries include the development of chronic and inflammatory changes at the level of the cord, as well as apoptosis of the neurons and the oligodendrocytes, and as well as compromise to the blood flow. I think we've talked about in the past when we were talking about our lumbar stenosis with neurogenic claudication discussions. We talked about how some of that can occur in terms of increased pressure in the canal, and as a consequence, changes in the blood flow, which ultimately can lead to some level of ischemia and edema, and ultimately injury to the nerves.
All right, that's a lot of ways that we can change the actual anatomy and what's happening at the pathophysiologic level. But what ends up happening for these patients clinically? So you kind of explained that cascade, kind of how the cord is being affected through dynamic range of motion. But what are these patients actually going to present like clinically?
Yeah, so as we talked about, definitely can be a variable presentation here, but some common clinical presentations include obviously neck discomfort, neck pain with compromise to the range of motion, and part of that may come in, obviously there may be due to the arthritis itself and the degenerative changes itself contributing to the loss of range of motion, but also, the patient's going to avoid, like we said, that flexion extension due to the stretch and compression on the cord that can occur. So neck pain, limited range of motion. Also, one thing to really look for, and when your patients mention this, to really, that potentially should raise some red flags in your head, is the loss of dexterity and difficulty with fine motor tasks of the hands. And so, the patient may report, difficulty doing the buttons on their shirt, or tying their shoes, or things that require a little bit of more dexterity or fine motor task. And if they're really reporting struggling with that, that could be a clue that we may be dealing with this clinical diagnosis. The other thing to think about and look for is the change in balance or even falls. Obviously weakness, numbness, and then, as I mentioned, bladder and bowel dysfunction. As the disease really progresses, those are going to be a little bit usually later findings in the clinical progression of the disease.
Yeah, and so the things you brought up and are obviously a spectrum of things that we see for patients living with neck pain or living with back pain, and as patients are aging, which this tends to be something of aging, you also can start talking about different forms of neuropathy that are contributing to the overall clinical picture. And so these can be fairly subtle things, right? Neck pain, obviously in our world, we see a lot of patients that come in with neck pain for a lot of different reasons, like you brought up, not necessarily just that stenosis or myelopathy that's causing the pain, but there's, the arthritis, the muscles, the discs themselves that can cause a lot of the pain for these patients, loss of hand dexterity or numbness, common things being common, carpal tunnel syndrome and things along those lines can also present with similar presentation to that. And then, talking about weakness or numbness or trouble with balance, like I said, a lot of different reasons for that, right? And especially if you are talking about, a kind of classical 70, 75, 80-year-old patient, there's a strong probability that there's some component of peripheral neuropathy that's affecting things. And so, I think, we have balance problems, and could the balance problems be peripheral neuropathy versus something else? So how do we then kind of go that next step, right? So, we have these patients that are presenting with these symptoms. The symptoms obviously sound great when you think about them all together, but individually, there's a lot of other reasons for that. So how do we start kind of working through, working up this patient, whether physical exam and imaging and such?
Yeah, and I think those are great points in terms of, especially because these signs and symptoms don't always come, completely together in a nice package, and they may be arriving at different time points. To your point, that's helpful to be aware of that clinical presentation, but definitely our diagnostic workup and exam becomes critical. So when we think about the diagnosis, so as we, I think, brought up in the beginning, degenerative cervical myelopathy, is a clinical syndrome, and that's why, that thorough history and evaluation of the symptoms we mentioned is crucial. But then when we look at the physical exam itself, so obviously we're going to be doing our typical neurologic exam with strength, sensation, reflexes. One thing that I would mention here in terms of the reflexes is that, if someone's coming to me and they're reporting neck discomfort and some, potential discomfort in the arms, weakness, numbness, and maybe that referral was, specifically for neck pain, rule out, cervical radiculopathy. But, especially if I hear any of the symptoms that we kind of mentioned, or if my suspicion is high for whatever reason, generally when I do my reflexes for the cervical spine, of course, you're going to do your upper limb reflexes in terms of the biceps, triceps, and brachioradialis. But I pretty much always do a patella as well. It's really quick, easy to do. And if you see hyperreflexia there, then it's going to be, raise even more concern for the potential for cervical myelopathy. And so, like I said, when you're doing those reflexes, obviously you're looking for, because cervical myelopathy is going to be an upper motor neuron process, you're looking for hyperreflexia of those reflexes. Now, one thing that I think is important to remember is that if you do not see hyperreflexia, that shouldn't necessarily rule out the possibility of cervical myelopathy, because again, these are typically going to be elderly patients that may have concomitant radiculopathy and or peripheral neuropathy, and things that may compromise those reflexes and make it so that they're not quite so hyperreflexic. And so the absence of hyperreflexia shouldn't necessarily be completely reassuring for the presence of cervical myelopathy. Now, the other important things on physical exam include the Hoffman sign, and so with that test, essentially, it's really important that you make sure that the patient's arm is really relaxed, and then you're essentially going to be flicking the long finger. So you're going to be flexing that that distal interphalangeal joint of the long finger. And when you put that on flexion, if you get involuntary flexion of the index and thumb fingers, so they kind of come together, then that would be, as Dr. Joves is
trying to
demonstrate
on myself.
Yeah, but yeah, so if you get that, so essentially if you get the flexion of the index and thumb coming together, then that's concerning for evidence of degenerative of cervical myelopathy. Now, the other, I think, really important test to do is tandem gait, because as we mentioned, because of the changes that we get altered proprioception and impaired balance, and as a consequence, these patients can really struggle with tandem gait. The one thing I would mention when you're doing the tandem gait is, again, these are elderly patients. They may be on anticoagulation for AFib. and so you just want to walk with them when they're doing the tandem gait. I generally am right behind them with my arms on either side, so that way I can really assess their ability to do the tandem gait, but we're also doing so in a safe fashion, and they're not having to fall in the room. The other thing you're looking for is clonus, so both wrist and ankle clonus, and keeping in mind that 3 or less beats of clonus potentially could be a normal variant or benign finding. So it's really that 4 or more beats of wrist or ankle clonus that would be concerning for myelopathy. There's other tests you can do, but like I said, those are kind of the more frequent ones that I'm looking for on my typical exam. Is that pretty consistent with what you look for, Dr. Joves, as well?
Yeah, I think those are the main things that we're always talking about. I think you brought up really good points about the understanding the other things that are going on, right? And I think that's the challenge that comes with this, because like you said, there's a lot of things that affect reflexes, and a 1+ reflex in an 83-year-old person might be hyperreflexia, which doesn't necessarily sound like it makes a lot of sense if you haven't been seeing these patients for a long time. And so it is a challenge, right? I mean, much like every single one of those symptoms, every single one of those physical exam findings can be affected by multiple different things. And so it does take a very astute eye to bring all of these things together, to be thinking about this as a possibility, and then of course making sure that we're doing a full and thorough workup to assess for it.
Yeah. And so along those lines, taking our diagnosis further, obviously we've done our history, we've done our exam. And then in terms of our objective workup, obviously we're going to be wanting to get imaging of the neck. So cervical spine x-ray and MRI. And, I do think there's utility in when you get that cervical spine x-ray to get a complete series, obviously including the AP lateral, but also flexion extension, so that we can assess if, with the degenerative changes in listhesis, if there is any dynamic instability that may be contributing. One thing, just as a side note, and to my knowledge, and I apologize if I'm missing any recent articles, but there is, some work being done in terms of trials looking at dynamic MRI, and how that may help us in terms of really identifying the severity and the progression, or the prognosis, and the surgical indications for our patients with cervical myelopathy. So just something to keep an eye out for in that regards. So, okay, to wrap up in terms of treatment. So I think maybe even before I get into kind of our typical algorithm for treatment, I wanted to bring up one other natural history study for cervical myelopathy, because I think it's an important thing to keep in mind. So when we think about the natural history of cervical myelopathy, one, I think, really well done and an important study is a study by Dr. Karadimas and his colleagues in 2013, which was essentially a systematic review of the literature from 1956 to 2012 that included all articles evaluating the progression and outcomes of degenerative cervical myelopathy, for which no surgical intervention was utilized. So just to reemphasize, so these are degenerative cervical myelopathy patients that did not undergo surgical intervention. And what that article found was that for those patients, around 20 to 60% of those patients, so essentially around half, I know there's a significant range there, but close to half of those patients that initially had mild degenerative cervical myelopathy on clinical presentation, and that was measured by certain tools, including the timed 10-meter walk, ADLS score, overall function status rating. So using those measures determined to have mild degenerative cervical myelopathy, what they found, like I said, was that 20 to 60% of those patients deteriorated neurologically significantly over time. And so that just I think it's important for us to keep in mind, and important to be able to counsel patients in that regards. And it kind of emphasizes that this is a disorder that is typically best treated surgically. So and obviously that surgery at a minimum can help to stabilize or prevent further neurologic degeneration, if not improve neurologic status. So bottom line from from our perspective, and for those of us listening who are not spine surgeons, the key here is to get those patients in front of a spine surgeon, not, and maybe they'll just closely observe that patient, but at least they've been able to lay eyes on that patient as soon as possible. So typically, if I do identify cervical myelopathy, and I don't think it's emergent where I'm sending them to the emergency department, but if I identify it, I'm sending an urgent referral to a spine surgeon so that they can be evaluated sooner rather than later. So now quickly going through our algorithm. So, we always think about our treatment algorithm of lifestyle modifications, activity modifications, therapies, medical equipment, medications, procedures. So thinking through that algorithm. So I think really the first one that comes up is activity modification. So this is where I really emphasize to the patient and to the family fall prevention, because, if someone does have cervical stenosis or early degenerative cervical myelopathy, and if they have a fall, then they are at risk of significant worsening of their symptoms and potentially even central cord syndrome. So now they're in a situation where they have a spinal cord injury, and we're dealing obviously with a more debilitating condition. And so really emphasizing to the patient that your health, your safety, your neurologic function is critical, obviously, and we really want to do everything we can to keep you as safe as possible and to preserve your neurologic function. And so, even a simple fall in this clinical scenario can be devastating. And so, just making sure that obviously not scaring the patient, but also the appropriate, as my one of my favorite MBA coaches, Greg Popovich, always said, an appropriate level of fear.
I think one of the things that comes in here is really, thankfully our physiatry training, right? Because fall prevention means a lot of different things to a lot of different people. And, I've heard from other patients where, they're like, oh, so I was told not to get in a car accident. I think that's a pretty easy thing. Most people probably shouldn't get in car accidents, right? But fall prevention being, how do you properly assess their normal day-to-day life and provide tools to decrease risks, right? And so, if it's an older patient who has some balance difficulties, making sure that there's a plan at nighttime if they have to get up to use the restroom, doing a home assessment with a therapist possibly, or at least a mobility assessment to make sure that they have those tools, grab bars, things along those lines, to decrease those risks, not just saying, hey, what would be really bad if you fell. And so just wanted to emphasize that, and kind of bring in, we are physiatrists, so we do actually think about all of those things too.
Yeah. And so, and I think clinically, obviously we, understand how busy every day can get clinically. So clinically, when you see these patients too, I think to Dr. Hoves's point, one thing you can do that can be really helpful is, assessing, okay, do they have a walker, which, typically at this point is going to be helpful to help prevent falls when they're out and about in the community and potentially even at home, depending on the severity. But, do they have a walker, and sending them to physical therapy, making sure the physical therapist is aware that we have, and I'll get to that, emphasizing that in a second, but sending to a therapist for gait training, fall prevention, balance. So those are, two simple things, asking what assistive devices do they have and making sure they have the appropriate assistive device for walking, and then sending them to a therapist for fall prevention, gait training. Along with the counseling that Dr. Joves emphasized. Now, in terms of therapies, like I said, I think the big thing is that when you are sending them to a therapist, making sure that the therapist is aware that we're dealing with cervical myelopathy, so that when that it's not like a cervical myofascial. You're just not sending them there for neck pain, and that the therapist is aware of the cautions they should take with that patient's neck. From a medical equipment DME standpoint, a cervical hard collar can play a role, especially while you're potentially waiting on updated imaging and the surgical consult. From a medication standpoint, what I would emphasize here is that a lot of times when we have patients coming in, with neuropathic type of pain potentially, or even muscle spasms, which oftentimes these cervical myelopathy patients are going to have some level of muscle pain, muscle spasms, neuropathic type of pain. A lot of times we would reach for things like gabapentin, tizanidine, baclofen, but just being aware that although you may potentially utilize those medications, just being aware of what's the age of that patient, what's the kidney function of that patient, what's their fall risk, because again, you don't want to prescribe a medication to try and improve their symptoms, but then they have a fall because of the compromise to their balance or awareness because of the medication. From a procedure standpoint, I would say that once you are concerned about myelopathy, to be very cautious with procedures and make sure that maybe Dr. Joves, if you agree or disagree, but my general approach is I hold off on procedures until they've seen a spine surgeon, and then I kind of work with the spine surgeon in terms of what we may or may not be doing. But I generally hold off on procedures until that updated imaging and surgical consult. Yeah, generally agree with that.
Yeah, I mean, I think caution is always the right play for these patients. Like whether it's with sending them for physical therapy, trying medications, or trying procedures. We always want to help. But we also want to make sure that first and foremost we're not making any more challenges for them, right? Making things worse. And so when we're talking about a very tight canal, the last thing you really want to do is load that canal with extra medication if it's if the risks are higher than what we perceive the benefits to be.
Yeah. And lastly, in terms of consults, as we already brought up, making sure that patient gets in front of a spine surgeon sooner rather than later. So that's as you kind of could tell from the treatment plan there. There's a lot of counseling, a lot of fall prevention to make sure that we're keeping these patients as safe as possible.
Yeah. No, I mean, I think that's the key, right? This is a diagnosis that we want to diagnose. We want to figure out what's going on. And so, as we brought up, it can be challenging when we're dealing with a lot of different things because these patients tend to be older. And so there are a lot of other disease processes, a lot of other diagnoses that can contribute to these symptoms, that can also make it seem like they're a part of the symptomatology. And so really putting together the entire clinical picture, really putting together all of the imaging and all of the diagnostic workup is what's necessary to make sure that we can provide the best care for these patients. One of the things we didn't bring up, and I just want to throw it in there really quickly, electrodiagnostic evaluations, I think, are really helpful for this patient population. We talked about that weakness in the hands or the difficulty with fine motor tasks. Common things being common, carpal tunnel syndrome is such a common pathology, especially in an older population. And I think that it's a quick thing that you can either rule out or rule in and figure out, obviously if it's, severe carpal tunnel syndrome that they've never had addressed, that can play a significant role in terms of what's causing some of the challenges with their hands, and is a much simpler procedure when we're kind of trying to get things taken care of. Or if you all of a sudden go and like I did yesterday for a patient who had similar symptoms, you do a screen and all of a sudden it's like, wow, your median nerve is actually sending quite a good signal for an 83-year-old. We're got to look at something a little bit differently because I think there's something else going on here.
Yeah, good point.
All right. That's all we got for this week. Thanks for listening and paying attention. Hopefully you guys made it all the way through to get this full take on cervical myelopathy. If you have any questions, please feel free to reach out to us. Hopefully we'll have one of our friends that might actually be able to treat these patients on with us in the next couple of weeks to kind of take us through some of those steps. But otherwise, stay tuned for those legal disclaimers. Dr. K, anything left?
No, that's it. Thank you.
All right, guys, we will talk to you later.